Okay. Thank you, Dr. Cheever. Good to be back. We have a great panel with us today. I'll just introduce folks quickly and in no particular order. There's Dr. Paul Sachs, who's at Harvard Medical School, who's been involved in antiretroviral therapy for a long time. Dr. Donna Sweet in University of Kansas, who has been at this really since almost the beginning and is extraordinarily experienced in antiretroviral therapy. We also have our co-chair, Dr. Iandora, who's here, and she is going to be participating and has been involved in antiretroviral therapy in New Mexico. Dr. Trip Gulick, who you met earlier, and he's back on the panel, and someone who we've alluded to and slandered his name greatly throughout the prep discussions earlier, Dr. Ray Filandovitz in Southern California at UCLA. So great panel. We're going to get started, and I'm going to share my screen here, and we'll get going. My disclosures have not changed from earlier today. They are the same. So we're going to go through a number of cases. I organized them really based on true questions that I get throughout the year that come in, and I try to organize them in terms of a stylized case. Every case will begin with a question, like I started with during the year, and these are the topics we'll be going over. The slow CD4 count response I will allude to, but not have a case on because of interest of time. I wanted to make sure we didn't rush through any of these. So the panel's ready, we'll get started. So the first question, seems like we are starting ARV therapy for about everyone. What about starting therapy immediately, right at the time of diagnosis? So this is a 30-year-old guy who was diagnosed on a rapid test in the emergency room 4 hours ago. Asymptomatic, we don't have any data back. The labs are otherwise normal, white count 3,800 with a lymphocyte count of 20%. Medical history is really unremarkable. He says, yeah, I'll start therapy if you want to. So panel, let's go ahead and start your responses. For the audience, start your responses, and we'll give everybody about 10 seconds to respond, and then we'll get the panelists to weigh in here. Okay. And I'm gonna, at some point, gonna channel my inner Richard Dawson from Family Feud, when it looks like we've got enough voting. All right, and here we go. Survey says, we'll push this out to the audience. And while the results are being shown, Dr. Sweet, I'll start with you. What's happening in Kansas on this question?
Well, we certainly have bought into as immediately as possible. We don't really have the system that we could do it in the ED, but we have case managers there and my own that will get the patient into my clinic the next day. And we've been then starting on the next day after that diagnosis. It's just a matter of expediency. If we could do it in the ED, we probably would.
Yeah. I'll just go down the row here. So Dr. Sachs, what are you doing in Boston?
Well, it depends on whether he was seen in the emergency department by someone who could assist with follow-up. So that would be either one of our outstanding social workers, who Dr. Landovitz might remember, or one of our ID clinicians. If nobody was able to see the patient, which would happen, for example, at nighttime, often we would then choose number two. But if we actually saw the patient, either the social worker, case manager, or the clinician, we would start right away.
Okay, and how often does that happen, Paul?
So
not that often.
You know, I mean, if you think about a week being 7 days, and of those 7 days, 5 of them there's very, very easy access, and in that time, 8 to 5, it's easy to get someone down there. But if it's outside those time periods, it might not happen. So
yeah,
you know.
Dr. Iandora, well, how about in your neck of the woods?
Sure, thank you. So in New Mexico right now, we don't have the option for number one. because as was mentioned, really the multidisciplinary team is really key for Rapid Start. So we certainly can do number 2 within 1 to 2 days, particularly in our metropolitan areas, but the more rural areas that can be a bit challenging. And so we might get to 3.
How about Manhattan, Dr. Gulick?
Thanks, Mike. The New York City Department of Health really has worked hard to try to make number 1 a reality, with some of the caveats mentioned by others, that the logistics of it can be challenging at times. One thing that hasn't been brought up is, why did he come to the ED in the first place? And there may be reasons there that would want us to hold off if he had another pressing issue. But 1, 2, and 3 are all reasonable issues. But I think increasingly we're steering towards number 1. Okay.
And last but not least, Dr. Landovitz.
Yeah, I would agree with what everyone has said already. You know, I think in LA we have a very large geography and various parameters that factor into whether people will be willing to start treatment right away. I think we aim for 1 or 2, but establishing what's geographically desirable for people to be able to follow up appropriately, and whether or not they want to be seen close to their own community. In LA, we have a lot of people who will only be seen in close to their own community because they don't want to travel, and public transportation in LA is challenging. And some people who don't want to be seen in their geography for fear of stigma. So making sure we had follow-up planned, I think, would be our limiting factor.
That's great. So I think there's a theme that's emerging, and I think, just speaking for a lot of the audience who have been hearing about this push to get it done right then in the ER, I think the logistics get in the way, the details matter about the follow-up. I think that's a common theme we're hearing. So what we do know is that the longer we wait from the time of diagnosis, especially if we lean into 3 and 4 weeks later, that's too late. The loss to follow-up gets too high. But I think it's pretty safe to say in that first week, you can get things done. Now, moving on to the next question. So what, in this setting where we don't have any data back, which would probably be the case if they were coming back the next day, that was an option. What type of regimen would you choose? Let's have everybody go ahead and vote. We'll push out the question to the audience and let folks look this over. I'll mention a couple things as folks are looking through this. We could have even the generic low-dose efavirenz, and we'll talk about that a little bit. Maybe some protease inhibitor regimens or some integrase inhibitors. I think folks are beginning to vote now. Nobody's mailed in their ballot, as far as I know. I'm not sure that's legal. It could be filled with fraud, so you got to be careful. They don't have any mail-in voting here. All right,
Dr. Saag playing with fire.
No, I didn't. I'm just making a neutral comment that it's a controversy. Let's go ahead and get off that topic. And survey says
not much controversy there.
Yeah. So it looks like the majority are going for a bictegravir regimen. Any one of the panel, I'm not going to necessarily go down the line. I just wondered.
I think an integrase inhibitor is critical. We know it goes down quickly. I had the experience just about a month ago where I started somebody same day as diagnosis and had a viral load that was in the millions and very active in the community in many ways. Started within the 3 weeks before he came back, he was down into the 100, 150 range. So it's part of public health benefit, I think, to get patients undetectable as quickly as possible. And an integrase will do that far better than anything we've ever had.
Yeah. Other thoughts?
There are a couple wrong answers here. I think there's a lot of right answers, but we wouldn't want to use an abacavir-based regimen because we don't have the HLA B5701 result. And we wouldn't want to use an NNRTI-based regimen like number 1 efavirenz or number 8 rilpivirine because there is transmitted NNRTI resistance in the community. So we really want to favor an integrase inhibitor. An older school approach would be a protease inhibitor, like number 9, darunavir.
Okay. Dr. Sachs?
I would have voted what everyone else voted. And one of the things that will be interesting is there's a single arm trial that has about 120 participants of number 4, because number 4 is clearly a very good choice for initial therapy, but not without some data. But this single arm study is testing this strategy of dolutegravir lamivudine in people as a rapid start strategy. And what we'll see in that study is whether it matters if they have a viral load greater than 500,000, or whether it matters if you don't have the resistance test, or whether it matters if they're hepatitis B surface antigen positive. And I bet you it's going to turn out to be very effective. It would be nice to see that as a comparative trial, but that would be tricky to do.
All right, let's decompact that a little bit, because you hit on some really important points, some of which came up in the resistance workshop. So typically we're trying to avoid the use of that regimen, dolutegravir 3TC, if a M184V is present, right? And so you're saying that maybe for a week while you wait for the result, it won't matter.
Yeah, it won't matter, partially because there's, first of all, very little 184V transmitted. It's usually about 1% of the newly diagnosed cases, if that, in the United States. And then second, I don't really believe this, but even if it is present, there are some who think that there's enough residual activity of lamivudine that you would feel fine using dolutegravir anyway. I mean, I disagree with that, but I think that one could easily make the point that if you start dolutegravir lamivudine and 184V is present, you can then switch to bictegravir FDC TAF, or or TAF FDC dolutegravir, and it would be fine. So we'll see.
Right. And then the third point was the hepatitis B surface antigen positivity using 3TC alone. Thoughts?
Yeah, well, there you're wondering whether that brief exposure to 3TC alone before you then are able to add tenofovir matters. So this is, I'm just trying to elaborate a little bit on this, because I would have voted the same way everyone else did, pretty much.
Right.
But I'm just saying, for just to make conversation, that there's at least an argument to be made that dolutegravir plus lamivudine isn't as crazy as it might seem.
Well, I think I'm glad you said that. Trip, go ahead.
Yeah, no, I was going to say, Paul, what about the other scenario, the greater than 500,000 viral load?
Well,
we don't have data on the
we don't have a lot of data on any regimen for people with viral loads greater than 100,000 or CD4s less than 200. Really, the best data come from the African studies, in particular NAMSL, and there, even triple therapy doesn't perform as well with high viral loads. So, and then if you look at the characteristics of the baseline characteristics, viral load didn't seem to matter in the Gemini studies. CD4 numerically did, but there were so few people with low CD4s that I don't think it made that much of it. I don't think we can make that much of it, although I personally would not use 2-drug therapy in patients with advanced disease that I know about. So,
yeah.
Just say Gemini excluded those patients up front.
With greater than 500,000, some of the people screened in with viral loads greater than 500,000.
Yeah, a handful, right?
Yeah.
So perfect discussion. This is what I wanted to get to. And the hepatitis B story, it usually takes about 18 to 20 weeks of lamivudine monotherapy to start generating what we would consider resistance. I think the 1 week probably is okay. The 500,000, as we just talked about, is uncommon in the US. The CD4 count there just aren't enough data on patients, so we don't know. This person had a viral white count of 3,800 and 20% white lymphocytes. So that puts them at whatever that is, at least 600-700, and then you figure 20%. So they're probably over 200. You don't know till you get the data back. Well, let's move on to the next thing. Now the data are back. So let's see how it changes how we voted. So it's a 48-year-old guy this time. Viral load is 28,000, CD4 count 650. Other labs are normal. Wild type virus, no medical history, normal renal function. He's B5701 negative. In other words, doesn't have that allele. So we'll put that on the table as well. So it's okay there. Let's push the poll out now so folks can vote. And it's a similar list to what we had before. And I'm trying to think if I don't really have many differences here. I think I took out the load. No, it's still there. Looks like the voting is started. And all right, there we go. We have that 20-second delay from the push to the pull. And there's a lot of folks who are leaning in several directions. We'll give them a little time to get this going before we go to our Richard Dawson moment. And okay, let's see what the survey says. Push that on out there. It looks like people have leaned a little bit more towards what is now answer 6, which is the 2-drug dolutegravir 3TC, based on the information. We still have a lot of folks with bictegravir single dose, some folks with dolutegravir TAF FTC, some folks with abacavir 3TC dolutegravir. We've had a nice discussion up to this point. Dr. Iandorio, what would you say in this setting?
Sure, thanks so much. So all of these options are either in the initial or the alternative regimen guidelines. So I don't think there's a clear wrong answer. I've been tending toward 3 or 5, although I do think given all this additional information, I would feel comfortable with 6. Yeah, that would be my preference.
Okay. Anybody want to take just a shot at why TDF3TC and low dose efavirenz might be okay? Wild type virus, lowish viral load.
If we're getting it for free.
Okay, so it could be a cost consideration for sure. Just to
work.
Yeah.
How about weight?
Yeah, there you go. There you go. We're going to get to that in a second. I think that's all we've been talking about for seems like the whole day. I think that the reason that's come out is that there have been, when efavirenz was first chosen as a regimen, it was clear that they didn't have time to dose find, so they leaned to the higher dose, and it's found that in a lot of populations that dose is a little bit too high. I just threw it out there. What about the abacavir 3TC dolutegravir?
If he had significant renal issues, but he doesn't.
Yeah.
Right.
But Tripp, can I play devil's advocate a little bit? If he had significant renal issues, why not 6 then?
Yeah, you could.
Yeah. And you might have to break it apart, right? Because depending on how bad the renal situation is.
Although, right, I mean, something that Paul taught me years ago is it's vanishingly rare that you actually functionally need to dose reduce lamivudine, right? Because what are you concerned about in terms of toxicity? So I actually very infrequently in practice do that, even with significant renal dysfunction. Paul, I don't know if that's still your approach.
Yeah, I mean, there are now some studies that have looked at the experience of giving lamivudine without a dose reduction in people with moderately impaired renal function. Nothing quite as low as sort of 15 to 30 estimated GFR, but 30 to 50, and it's fine. So
yeah,
I think one thing to sort of just throw out to the panel is now that we know that dolutegravir lamivudine works so well, do we need abacavir at all? And I would say no.
Yeah.
Right. I'll dogpile on that.
Some patients feel more strongly that they want something that's been tested for longer. I'd be open to it. If he said, I want 1 pill once a day, then he's got 4 options or 5 options here, right?
Yeah. And we could stay on this slide for the rest of the time, I guess. What about boosting? What does everybody feel about? Is that something we want to sort of shy away from if other options are available? Is that the general consensus? I'm seeing 5 heads nodding in unison. That's a good thing, I guess. Anybody feel strongly about continuing with a PI or a boosted integrase inhibitor?
I think drug interactions, side effects make boosting problematic, and we should not vote for it first.
Okay. All right.
It was a necessary evil with sequinavir.
Right. Yes, it was.
And still is for darunavir.
Yeah.
And just to say, it's the reason that L-Vitegravir was relegated in the guidelines to alternative rather than first line.
Yeah, it's just fascinating, especially for, I think Dr. Sweet and I are of a group of providers who have been at this a long time, going back to the time before there was any therapy, and just watching what was dogma one year becomes dogmanure the next year. It's kind of interesting to see that evolve.
Your karma can run over your dogma too.
That's right. So let's get to some more thoughts digging into the TAF, TDF, or either. Let's go ahead and vote on this. Do you feel strongly that we should use TAF if they're equal? If renal function normal, 48-year-old guy, let's go ahead and vote. Not sure I see a vote coming up. Maybe that one. Oh, here we go. Okay, so here we go. People are voting already. It's a horse race. Give it a few seconds more. All right, survey says it looks like TAF is about 60%, and the combination of either or TDF is the remaining 40% or so. Dr. Sweet, thoughts?
Well, the TAF, I think, has gone a little bit south for me because of the weight gain issue until we figure that one out. There's so many, especially my women, who are desperately against gaining any weight, and they all know that this is a potential right now. So that's why I would say either, with the weight throwing me towards TDF if that was necessary. Then there's always the issue of pregnancy in women, especially.
We're gonna get to that in a little bit.
Yeah.
Any thoughts strongly one way or the other?
I have found it very liberating to use TAF over TDF because, TDF was approved in 2001, and over time, more and more people started to have issues with renal dysfunction and bone density having to do with both TDF exposure and the fact that they were getting older. And I am aware of the weight issues with TAF. I am still not sure whether the TAF weight issues are some direct toxicity of TAF or whether it's the absence of TDF. I think one could make an argument that for on both of those sides. So I would definitely use TAF.
Okay. Great. So coming back to the bigger picture here, I'm just going to move on quickly here. And so we have these sort of choices that are a lot of them. This was worked out in a study and showed that it really didn't seem to matter whether using TAF or TDF with dolutegravir did better than efavirenz. I'm going to skip that slide. The weight gain we talked about, which again, I can't tell if the weight gain is among the patients we're treating, and in my case, it feels like I'm gaining weight as I prescribe more of these modern regimens. I'm not sure if there's a correlation.
Mike, well, we all are.
Yeah.
Go back one slide if you don't mind.
Sure.
When these data came out and they show weight gain in both groups, a lot of people said, well, women continue to gain weight, but the men are plateauing. But the data that I presented this morning, which was another year of follow-up, actually show that the men continue to gain weight as well. So yeah. I think that was sobering.
Yeah, and to Paul's point, this was an interesting study that Andrew Hill and his team just updated. And they took, it was basically a meta-analysis of all kinds of studies over the years and did not show any overall benefit in terms of renal toxicity in the phase 3 studies, or in this case, the bone toxicity. Now, in fairness, what they did see was that when there was boosting, you tended to see a little bit more problems with TDF. And that I think most people would agree with. If you're going to use a boosted anything, you're going to probably want to use TAF over TDF. And I think that's a take-home point. The issue with this study is that it's all pretty much younger folks. It's not the people Paul was just talking about. And so this study's coming out in the journal AIDS in about a month or so, and there'll be an editorial that makes those points. Any other comment?
Yeah, I was going to just say what you said. These were all clinical trials, so you had to meet entry criteria to get in, meaning they did not take people with baseline renal significant dysfunction or significant bone issues.
Right. So the way it, just to sum this up so we'll move on, is that when TAF first came out, TDF got demonized to the point where it just got put in the back room and nobody wanted to deal with it anymore. Now I think there's a little bit more equilibrium that's happening that said, if there's situations where you're worried about these types of toxicities, of course you're going to use TAF preferentially, but if there's a cost issue, Michelle brought that up earlier with the fog rooms, but if there's a cost issue or other things going on, I don't think you're really committing a cardinal sin. And the guidelines are saying, for the most part, they're equivalent and you have to make a clinical judgment.
Mike, I think just the other thing, just before you move on, just to, of course, remind people of is there's been a fairly significant campaign on social media with class action lawsuits claiming or alleging renal or bone harm from TDF-based regimens that really have influenced patients' preferences and willingness to take it. So it's just something else I think we need to keep in mind. And you know, all the data in the world sometimes isn't going to sway people in those sorts of contexts.
Yeah, and that's an important criteria. I think we've really talked a lot about weight already. I'm going to sort of fly through these. I'm not going to spend much time discussing. This is basically a case of someone who started on a bictegravir-based regimen or switched to it after darunavir. Basically, the weight went up about 26 pounds or so. So what would you do? This gets to a question that Dr. Gulick got after his lecture. Let's just go ahead and vote on this real quick. See what the survey says, and then we might just move on quickly, but see what the voting does. So the poll's just been opened up.
Mike, what was the reason that she switched?
It was the newest thing. Okay, let's see what the survey says. All right, looks like most people would keep her on what she's on. Tripp, you've already answered this already, that there's not much besides exercise and diet. Do you have anything further you wanted to add?
I mean, some people might try switching from TAF to TDF. I don't know if that works. We're about to start a study looking at people like this that would switch the integrase inhibitor to doravirine, which has a relatively neutral profile on weight, but that we don't know if that's going to work or not.
Yeah. Any other thoughts from the panel? I think I may just end up moving on here a little bit.
Yeah, it's really, we're at the point where there's not even a small case series showing that weight improves with switches. There are merely anecdotes that, who knows what that means. We don't have time, but I have a really good anecdote on this one day. I'll tell you.
We'll come back to that. These are the data from earlier. What I found fascinating is that if you eliminate the first year, it seems like a lot of the change happens in that first year, and especially in the first several months, and it continues in an upward direction. But I think if you looked at the general population, a lot of people are gaining about a pound a year on average. So it's hard to say what that is.
Mike, can I ask the panel something?
Sure.
Is anyone, I mean, that 1 year brings it up because is anyone addressing the issue of counseling patients before we start therapy based on, you know, they want one pill once a day, period, but telling them what possibly could happen and seeing if we could head it off by dietary and other things? We all know it's much easier to not gain than it is to lose once it's there.
Yeah.
Really,
it makes sense. Yeah, we should warn people.
We do definitely mention it to people now as a side effect of treatment.
Yeah. And we've already talked about all that. Let's pause. You have my curiosity, Paul. I want to hear your anecdote real quick.
Sure. I had a patient whose initial regimen was TDF, FTC, raltegravir, who then switched to TAF, FTC, dolutegravir, and gained a whole lot of weight. And I wasn't sure whether it was the dolutegravir or the TAF, but he wanted a single tablet, so we switched him then to bictegravir, FTC, TAF, and lo and behold, he loses all this weight. And this is before we had analyzed the weight outcomes from the bictegravir trials, and I was thinking, oh, isn't this amazing that switching to bictegravir led to weight loss? Of course, he had changed his diet, exercised more, and all these other things. And of course, as often happens, a year later, all the weight came back on. So these anecdotes are not very useful.
So in essence, he's like the rest of us.
That's right.
Or most of the rest of us. Okay, let's go to pregnancy at this point. There's a 30-year-old who presents newly diagnosed HIV. She, at a presentation, is 2.5 months pregnant. She got tested when she showed up for her prenatal visit. Viral load and CD4 are pretty good. B5701 negative, wild type, genotype. First pregnancy, no other medical history. Let's go ahead and get the poll started. Which regimen would you use? Choices here. We've already seen some data. Great. Michelle, I may go to you first on this one and see what your thoughts are from the New Mexico perspective. Okay, let's see what the survey says. And Dr. Indorio.
Yes, thank you. So the preferred regimens for treatment-naive pregnant women would have included TDF, FTC, or bacoviral imivudine. But I think given what we recently heard this morning, that now there's more data on the use of TAF. We do use there's lots of more experience with the boosted PI in pregnancy than integrase inhibitors. But quite frankly, what we do here mostly is keep it simple. And the most important thing is that mom takes antiretroviral therapy that's very tolerable throughout her pregnancy. And so we often use the single tablet regimens. We've had women do fine. We do enroll them in the pregnancy registry so we can learn more about that. But to me, that's the big take home is like, what is this woman going to take and can she tolerate?
Yeah, I remember thinking when the perinatal guidelines always were, lack of a better word, a little bit more conservative, because I think in general, obstetricians are by their nature, they see the complications right up front. When they do a delivery and there's a problem, it hits them. So they're going to be very data driven. Like to say we aren't, but they were. And I remember years ago, they kept insisting on using zidovudine on every case. And then when lopinavir came out, they added that together. And I thought, do you all hate your patients? Do you want them to be hurling every minute of the day? And so, tolerability is important. Dr. Sweet, thoughts on this?
I agree that we need to make it as simple as possible and make it something that the woman believes in and knows is critical to take. So the easiest, the simplest, and the least toxic, which would be number 5 here.
Yeah. So let me share a little data and then we can come back to the discussion specifically here. So this is a little bit of a busy slide I put in just more to share with the audience, but I think Dr. Gillick covered this pretty well in his What's New in this study from Africa in general showing more rapid decrease. And I think the take-home point at the end of the day is that perinatal guidelines have changed because of the downward trajectory in neural tube defects, such that it's now it's a preferred in general integrase inhibitor. Raltegravir is still there, of course, and that would be a good choice. What's interesting is that the last 2 bullets, dolutegravir TDF FTC recommended for acute HIV in pregnancy, and it's an alternative for women trying to conceive. So you can use it later in the course of pregnancy with no worries at all, hardly. But for the women trying to conceive, anybody want to jump on and try to clear that up? But this is a question that you now will get right on your pre-test, post-test, because the dolutegravir is the correct answer on that. I'm just telling you. And the atazanavir, which a lot of you went for, was non-boosted. And you don't use non-boosted atazanavir in pregnancy because you won't get levels high enough. So anybody want to take the discussion about why this might be nuanced here between trying to conceive and already into pregnancy?
I'll jump in just to say that the SAPAMO saw the highest rate of neural tube defects in women who were administered dolutegravir at the time of conception. Although, as you just said, that number, every time they look at it, goes down. And so I think this is a holdover from the last time. It'll be interesting to see if the perinatal guidelines keep this in.
Right. And if we go back, go ahead.
I was going to say 2 other points to make. People sometimes turn to bictegravir here. Remember, everybody, that we don't have a lot of pregnancy data on bictegravir. So the perinatal guidelines say not enough data to recommend. And then the TAF question, I alluded to this morning that we now have the VESTED study, which is the largest experience with TAF in pregnant women that's ever been looked at. And it showed fewer adverse events than in the TDF arm, interestingly.
And not only that, but the women in that arm who gained more weight than the other arms had the weight gain that was closest to the recommended weight gain during pregnancy. Another indirect piece of evidence that TDF may be suppressing weight and that it's the absence of TDF, not the TAF itself, that's causing a problem.
Interesting. Well, I think for whatever respective schools we went to get into this room as an audience member, be it pharmacy school, nursing school, medical school, we go back to embryology, and we know that the neural tube forms in the first 6 weeks. So that train has left the station by the time week 7, week 8 has happened. So dolutegravir after that time should be no problem, especially by definition with regard to neural tubes. The other thing we also know from prior work is that folate is critical for normal neural tube closure. And so I think if I were, I know what I do is if I'm talking to a patient who wants to become pregnant, and in that planning phase, get them on folate. Doesn't hurt. It's important for development. And there are some data showing that dolutegravir does interfere a little bit with folate metabolism, and that could be part of the mechanism. And my final comment is that all of us, I think, on the panel for sure, remember back to the launch of efavirenz, and it went through the exact same thing, right? It had neural tube issues that have shown up, and then after about 2 years of follow-up data, that gap started to close, no pun intended, in terms of the incidence of neural tube deficits, so defects. So it feels like it's deja vu all over again, to quote Yogi Berra. Okay, let's go ahead and move on. Changing subjects. It seems like now we're starting art therapy for everyone, but we have these folks who we call elite controllers. That is, people whose viral load is persistently undetectable despite the fact that they have, as we say in the South, sure enough, HIV infection. So let's see this case. A 30-year-old guy diagnosed 7 years ago, is asymptomatic. Every time you check him, his viral RNA in the plasma is less than 50. You were worried maybe at some point about it being a false positive antibody test or something, but the HIV DNA, cellular DNA, was positive. CD4 counts hovering right at about between 750 and 900. Everything else is normal. And he's okay to start therapy if you want to. Would you start therapy on this guy at this time? Let's push out the poll and see what folks think. Dr. Sachs, this is likely to come right at you because of colleagues of yours who work on this question in large numbers.
Paul also was intimately involved in the one study that best informs this.
Yes.
Relatively large numbers. I would never say, nobody's studied this in large numbers.
Yeah. So all 28 of your patients. So I'm not seeing the poll on my computer, but let's just go ahead and have a discussion about it.
Yeah.
So Paul.
So one thing that is very important is that this patient has had now, how many years? 8 years of undetectable viral loads?
Yeah,
right?
7 years,
Yeah.
7 years.
So it's very different when you have 8 years of follow-up versus when you have a newly diagnosed patient who has an undetectable viral load. In the latter, those patients frequently lose virologic control when they're followed longitudinally. And the best data come from Spain, where they have a cohort that they assembled, and over time, really very, a relatively small proportion of the initially diagnosed controllers maintained virologic control or immunologic normalcy or no progression otherwise. But you have 8 years here. So that means, do we really know? We don't know. We do know from the study that Rafi alluded to, and that was led by John Lee, that giving ART to this population does seem to improve certain laboratory evidence of immune activation and what's called immune exhaustion. So it had benefits that were measured in the lab, and people acted as their own controls. So we followed them for a while with no ART, and then we put them on ART. And so it was actually, a positive study in that way. However, there was no way we were going to demonstrate clinical benefit in this trial, because these patients have really years and years of HIV control and no HIV-related side effects. Plus, things like the CD4 cell count didn't improve. Even like the HIV DNA, meaning the measurement of the reservoir, didn't improve. So I would say the data are still mixed, whether people like this should go on ART. If people want to go on ART, by all means, offer it to them. If they don't, continue to follow them closely, because some of them will progress. And once the CD4 starts to go down, they don't respond as well to ART as people who have HIV viremia when they start ART.
Okay. Other thoughts from the panel?
But one thing, Mike, I would just add to that is the other question that a lot of people sort of ask in the era where U equals U is so high in people's mind is, that makes the assumption that people are on therapy. And, what about sexual partners of these people who are undetectable off therapy? And, we honestly don't know the answer, but the U equals U definition really is best supported by a viral load less than 200. So your sense of things, your gestalt, would be that would apply to people who are so-called elite controllers, as long as they fit within that rubric. But you could make an argument that they may be blipping up higher than that periodically between measurements. And therefore, an understanding of what they're doing with their sexual partners might be important to go into that decision tree.
Yeah, I think that's exactly right. Paul, I'm sorry I didn't reference your study. I would say, though, to your point, Rafi, is that the Rakai study with Uganda back in 2000, the quintile that had a viral load of 1,000 or less, none of the paired discordant couples had transmission. So I think it probably is a viral load issue or function, but you're right, there aren't data. And the other point is, from my perspective, these folks, their immune systems are churning. They're working to keep the virus suppressed, is how I would interpret this. And so you're giving a little air support for the infantry here if you give antiretroviral therapy. The other thing that a number of studies have shown is that if you look at certain immune markers, but I think the best one is CD4 to CD8 ratio. We have that on almost everybody. If that ratio goes less than 0.5, then that's someone you ought to lean towards treating, regardless of the viral load. Did you all find that too, Paul, or do you remember?
So CD4 CD8 ratio was already normal in the people who enrolled in the study.
Okay. All right.
And then they went on ART and it stayed normal.
All right. That's progress.
So one thing, though, there are some people who are controllers who have detectable virus below the level of detection. And so in single copy assay, we did find that HIV RNA went down when they started ART.
That feels definitive.
One other thing to add, we usually present the pros and cons to the patient and then make a decision. And
yeah.
I think important if they say, I don't want to start, that we tell them we're going to support you. We support that decision, but let's follow you closely.
Yeah.
And we're going to readdress every time we see you, whether you should start or not.
Yeah. And the follow closely is a critical concept. So we're following this patient closely. He has persistent detectable viremia. So this is a 55-year-old referred for evaluation. Diagnosed 18 years ago, had almost 1 million copies and a CD4 count of 70. So this is a patient Dr. Sweet and I would have seen back in the day for sure. but now is on a regimen, and the HIV RNA never goes below 50. It sort of hovers between 50 and 85 or so, and has been through a number of regimens, but currently is on dolutegravir, boosted darunavir, and 3-TC. No available resistance assays. So would you change this person's antiviral therapy now? Let's push out the poll and get some voting. So the question is, would you change their therapy because of this persistent low level of viremia? Little different than a blip, but maybe the same biology. So let's see what the survey says. It looks like a lot of people, maybe up to 70%, would change their therapy. Dr. Sweet, what do you think?
Well, it's hard to know. I think I would agree gestalt-wise to change it. I'm not sure how lucky we're going to be getting it any less than it already is.
Okay. Other thoughts?
Mike, remind us how long he's had this detectable viremia.
It's never really gone below 50 copies, just kind of hovers, maybe goes to 45, never gets less than 20, but it kind of just hovers.
What period of time?
Years, just not going up. Yeah, not going up. Just every time you check, this is a guy who's persistently viremic.
Okay, so I would have a different opinion and say that this guy may just have a higher set point than the arbitrary cutoff for detectability. And back in the day, we used to do studies of people like this and add agents or switch agents. And so I would be comfortable keeping him on his same regimen.
Yeah, and that's, we're running a little bit short on time, so I'm going to rush through this a little bit, but this is what we want to see, right? And this is a blip. This guy's a little different than both of those, where the viral load is certainly less than 100. And the way that I view this goes back to this sort of pathogenesis concept, where the number of cells in the body here, especially the latent reservoir, seems to go up with people who had a really high viral load at baseline of 1 million copies. That we know that viral load is proportional number of cells in the body producing virus. So in this case, I think it's just residual cells that are spitting out virus here and there. And as we could call it a set point, whatever, an antiretroviral therapy set point. But back in the day, we did several studies where we added additional therapies as they came out. And it's sort of like Paul's result. It just stayed the same. We didn't get any extra boost, which tells me that there wasn't a problem with the antiretroviral therapy blocking the infection of activated CD4 cells. Rather, it just was a biology of the nature of the reservoir and how that played out.
So what do we tell him about U equal U?
I think I would say it's okay, personally, because it's less than 200. But I don't know if people disagree. Rafi, you're the maven over there on prevention.
Well, I don't know that I'm a maven, but I do think the data support less than 200. You know, the Rakai data that you mentioned, less than 1,000, but the more modern data with conventional regimens, certainly less than 200.
Yeah.
Rakai was actually less than 1,500. They saw no seroconversions if the partner was less than 1,500.
So this question comes up in clinic all the time, and I prefer to give the optimistic response than the one I heard from the esteemed virologist, Dr. Mellers, who said, these are replication competent virions, and until we have enough prospective data, we can't say for sure. So I usually go with the studies were designed using 200, so that seems fine to me. Right.
So we're almost out of time. This really isn't a case. I just want to make a couple of points, echoing Dr. Gulick's slide earlier from a different study. This is what Scenic showed. It's a group I'm involved with, but those with limited treatment options are vanishingly small these days. It's rare that we're really encountering this, but this I thought was the most interesting part. If you look at it 2016 to 2018, the few patients who had limited treatment options, virologically, we could get them back under control. So it means that with all our existing agents, the primary reasons why a regimen doesn't work is because it's not taken, right? And if you give people something that they can tolerate, they usually have success. I know there's exceptions, but I think it's pretty good. So to wrap this up and go to questions real quick, confirm the virologic failure if it happens above 200, explore all the prior regimens with resistance tests. This is just more discussion about what to do with a failing regimen. Identify 2 useful drugs. We've heard about fostemsavir, recently approved. Ebolizumab is one that we could use as well, but typically we can get folks under control. The timsavir, we've already seen the data. This is for fostemsavir, and I'm going to skip the data because we've already seen it. And so conclusions, we should initiate therapy typically with an integrase inhibitor-based regimen. Don't change therapy in general with low level of viremia if you know it's persistent and not, especially going above 200. We didn't go into CD4 count responses, but that's a similar story, that just some people have a discordant response and changing therapy isn't going to improve that. Dolutegravir is really a drug of choice in most women, but make sure we give folate. And if the person's contemplating conception, you might think about a different agent because of neural tube issues. Weight gain, we talked about ad nauseum, and then 2 active drugs if possible in treatment failure. So I'm going to stop there. Thank the panel. Great job. Good discussion. And I think we have time for some questions and answers. So I'll stop sharing my screen and just see what kind of questions we can get to. Dr. Cheever, I'll turn the questions over to you if that's okay.
Okay, so I'm just seeing them for the first time as well. So do you start therapy before you have a confirmatory HIV test? That gets back to that rapid start question at the very beginning.
Yep. Panel?
Depends on your prior probability of whether it's HIV or not. So there are quite a few people with reactive screens that are not confirmed these days. We see this most commonly in our pregnant patients. But you know, if you have a high likelihood, then I would definitely do so.
Yeah.
So it's really risk-based.
Yeah, I would agree. It depends upon the history of why they had the test and whether they fit the logical person that's going to have it. Pregnant women, I do not have them get started on anything until I get some confirmatory tests.
Agree.
That's where I've seen the false positives.
Yeah. 50% of our reactive tests at our institution are not confirmed.
It's interesting.
Wow.
And it depends on the access to medications. And so if we have a patient without insurance, in order to get them enrolled in Ryan White services, we need that confirmation test.
Oh, great answers.
Great, thank you. And for someone who's severely obese, does that really change what INSTI you start? They already have obesity at baseline. They've proven they have extra weight, which is obviously very bad for their health. Does that affect how you treat their HIV?
Anyone? All right, I'll go ahead, Chair.
Yeah, I was just going to say it merits a discussion, but I don't think it would prevent you from using an INSTI regimen.
Yeah.
Obviously, we're going to want to talk about it in some detail. If they're severely obese, that health issue is actually the most important one.
Yeah. I think that's right. We want to get the best therapy for folks, and if we thought that there was something that was dramatically different or could cause weight loss, I guess if you gave zidovudine and lopinavir together, you might cause some nausea, and but that would be cruel. So we'd never do that.
Right.
And there's a high likelihood of discontinuation, of course.
Yes, that's true.
Right. So what are the current thoughts on the cardiovascular risk of abacavir?
That's a case I had in there that I took out because, as we already decided, it might be moot. But Donna, what do you think?
It's become a non-issue for me because I simply don't use it, and I haven't had a place where nothing else would help. So, in fact, I'm no longer doing 5701s on all my new intakes simply because it's a lot of money for something that goes unused.
But what about the people that are on abacavir? I think that people that have been around for a while, many of them are on abacavir and may not want to switch their regimens for the reasons that people just feel wedded to the regimen that saved their life. How hard do you push then if they have diabetes and other cardiac risk factors?
Oh, I don't push real hard, but I do discuss with them the fact that there may be some increased cardiovascular disease. It's still kind of an unknown in many situations.
Yeah.
Very funny. just historically, I had a conversation with a virologist back in the late 90s when, and his comment was that they weren't sure that abacavir necessarily added any additional antiviral activity to lamivudine, and he was surprised that there was going to be a combination regimen that included those two drugs. So I think given what we know from the Gemini study and given what we know about other very well tolerated agents that don't have this signal, I don't see any reason for someone with cardiac risk factors to stay on abacavir in 2020 unless there's something really compelling about it, and I can't think of what that is.
Maybe it'll prevent COVID. just kidding. I'm just kidding. Sorry.
TDF.
I think I agree with Paul, and I think the other thing that's often a selling point when people don't want to switch is if you show people the comparative size of the two tablets, that often is amazingly persuasive.
Yeah, it's true.
And of course, I'm referring to Biktarvy.
Yeah. So I think the bottom line is it sounds like it's moving towards the place where DDI lives now, which is not used very much.
Right. I think a lot of these other questions that have been asked were actually answered during the presentations today. Question came up again about that Impact 2010 data showing that 24% of mothers on dolutegravir FDC TAF had adverse pregnancy outcomes compared to 33% of mothers in the other arms. I think we've addressed that also earlier today. So I think we've addressed a lot of these questions.
Sorry, Laura, that's the vested study that we referred to a couple of times.
Yeah.
And those percentages look high. This was a prospective study, so they collect every side effect on that study. So lots of minor side effects are included in those percentages.
One thing I think you may have discussed this during the course of the day, but there's a numerical imbalance in dolutegravir versus efavirenz in transmission to the newborn. Mm-hmm. That was shown in the meta-analysis that was presented at the AIDS 2020 meeting. And that's may just be by chance. It's small numbers, but it's worth keeping an eye on just in case as we put dolutegravir now in the water for all our HIV positive women, just to see whether there's something going on there that we don't really understand.
Yeah, can you roll up the questions a little bit? There are a couple more at the bottom I can't see. Do we know anything about the mechanisms of weight gain? Is there a single phenotype?
We do not know that. It's a subject for research right now.
Yeah, and can you just speak briefly to the culture of HIV medicine where we're very fast to adopt the newest thing. We have a lot of sort of pivots in practice because it's new and someone comes in and we think we need to do something for them that day.
Yeah, maybe I'll take part of that. Just having been at this a long time, we're kind of we become one-tracked, and the history we tend to forget. So, for example, linking starting therapy to a CD4 count goes all the way back to the original AZT study because they didn't want to give a potentially toxic medicine to somebody who might not need it. So they put as the entry criteria CD4 count less than 200 or prior pneumocystis pneumonia. That's how the study was done. And that almost got copy and pasted into the entry criteria. And from that point forward, for the next 20 years, we were plagued with that continued history until we finally started thinking together that the biology was important. And it was screaming at us, you want to suppress replication. That's a good thing. And so I think when new things come along, they tend to be shinier and brighter, and the company that made them and launched them is going to take shots at what was there before because they want to have an entry into the market. And I think that plays into a lot of what we see and do. And I think it's just a question of maintaining some degree of balance as we move forward. I don't know if others have opinions as well.
Well, I think we lived for so long not being able to do what we wanted to be able to do for our patients, and they all died. Once we had options, it just it seems more right to do the newest and the best just in case you're going to save one or two people.
Yeah.
We didn't have that option before.
This is Laura. I think I can also add, I've reviewed a couple of papers where people were saying incorrectly that looking at the HHS guidelines, looking at the what to start, and then comparing it to what people were actually taking. And obviously the what to start on patients newly starting therapy, not what to start on every patient you're seeing that day in your clinic. And I think that gets conflated. As I said, there were 2 papers that I suggested they reject, and they did because the analysis was incorrect. So, so I think that that's an important thing too. I think that the fact that what to start gets so much attention and it's such a small proportion of the patients we see really gets people kind of mixed up a bit. In addition to the direct advertising to patients and all the rest of it that we've talked about.
And I'll make just a quick comment about guidelines. I mean, they're just that. They're guidance. They're not directives. They're not hard and fast rules. It's still up to us as providers to match up what the patient in front of us is up against, what they're thinking about. It could be like Rafi said earlier, they're concerned about this lawsuit. They're bringing that to the table. We have to be, we have to be providers. We have to think in that individual situation. The guidance gives us a starting point, but it's up to us to make the decisions.
And the guidelines actually stress that point.
Yeah.
That treatment needs to be individualized to individual patient circumstances.
Right. What I might do, if it's okay, since we have a few minutes, I took out the question. I think we saw a couple of things come in on CD4 counts.
Right.
So
thank you.
So let's say we have a scenario. This will be kind of an impromptu case where someone had a CD4 count of, say, 45, started therapy, high viral load. Viral load comes down nicely, and the CD4 count just barely budges. It goes to 70 and then maybe 90, and then 3 years later it's still at about 120, and it just didn't rise like we were expecting. And the point of that question was, and I'd like people's input, but the way that I look at that is that there are studies from back in the day of lymph nodes that showed that when people have high level of viral replication, there are adhesion molecules in the lymphatic tissue that trap cells. And when you stop the viral replication, those adhesion molecules are not elaborated like they used to be, and the cells, for the most part, release back into the circulation. So a lot of that CD4 bump that you see with antiretroviral therapy happens in the first 6 to 12 weeks, and then it kind of levels off to a slow uphill climb, but it goes. The people that tend to have that, like a case I showed, they don't get that initial bump. It's almost like there weren't trapped lymphocytes inside a lymphoid tissue. I'll think of it like demargination of white cells when you give steroids, and you just get this slow rise. And there's nothing that we can do about that biology. You either have it or you don't. But I wondered if any of you all had other thoughts on why those patients struggle with the CD4 count increase.
Well, I don't know why particularly, but I do know in following them, some of them for up to 15 years, they don't get sicker than anybody else, and their CD4 count seems to do what it needs to do. So, and the data shows us adding medicines has never helped to bring the response up. So I counsel my young ones not to keep chasing a CD4 count. Give the patient time, follow for a few years, and watch for any signs or symptoms of infection, opportunistic.
And I think regarding CD4, I have several cases like that too as well. And staying the course, they ultimately come up above 200 at some point, but it takes a long time, and they do well overall. That's correct. Any comment from you guys, Trip, especially with the HHS guidelines, about when can you stop checking CD4 counts, or should you?
Yeah, I think over time, the guidelines have been more proactive about not doing unnecessary CD4s. So someone who's consistently suppressed, we know their CD4 won't fall. So having a CD4 above 400 to 500 and continually suppressed, there's no reason to continue checking.
Yeah. And Dr. Sachs was saying that quite a while ago.
Yeah, I mean, it's just that you have to sometimes have to do a little extra patient education to wean people from getting their CD4 measured, just to sort of tell them, we're not going to change anything anyway. Save you a little extra blood, save a little extra healthcare, a little system, a little extra money. It really infuriates me when our local ADAP requires CD4 on the form. It's just so infuriating because Why are they
Uh-oh.
why they still want it?
Sounds like direct feedback to Dr. Cheever and her
Yes.
hat.
Yes. Well, thank you very much. This was a great panel. Thank you so much. I just have a couple of slides in closing out today. Thank you all.
Thank you. Thanks to the panelists. Really appreciate your active input.
I miss you all, even if it's virtual.
Yes, thanks so much. So in closing out this afternoon's session, can I want to remind everyone to please fill out your evaluations. It is on the main evaluation, on the main site. You can go down on the far left is the evaluation tab. If you keep signing in from the same device, you can continue. You will need to complete your evaluations as part of your CME. So please do that. We take the advice you give us very seriously. And you'll see many of the suggestions you've given us reflected in our meetings from year to year. Next slide. The case presentation slides from this last session were not available on the platform today because we wanted it to be spontaneous and for you to be listening and answering based on your experience, but they will be posted and the webcasts on demand will be available in the platform in the next couple of days. Thank you so much for joining us. Remember that we will be meeting back here tomorrow morning at 10 a.m. Eastern Time, 7 a.m. on the West Coast. We have another really exciting day, I think, with some excellent presentations. So I encourage you all to return on time. And please to consider being part of our, when you're on your Zoom meetings for the breakouts, to please put on your Zoom face. We don't have any expectations of hair or makeup or anything else. So please join us in person tomorrow on the Zoom. Thanks so much. Have a great evening. Thank you.